certainly a pleasure to be here today. Thanks to Pain Alberta for the opportunity to share a little bit of my work. And it's certainly an honor to be invited to participate with the great lineup of speakers that has been running across this amazing and really inclusive event. So my topic today is deconstructing desensitization. So let's start with, what is desensitization? Well, desensitization is a strategy broadly to control or change sensory and nociceptive inputs and processing, and thus the pain experience. And this has been used in both acute and persistent pain states. These inputs can be tactile, thermal, or proprioceptive, but desensitization is also talked about in the areas of allergy, pharmacy, psychology for phobias. So when we talk about it related to pain, we really need to be specific about it, because even there we actually have a rich literature on the use of things like capsaicin for desensitizing ion channels to alter the transmission of nociceptive signaling. So in rehabilitation, the term desensitization generally has been used as an umbrella term for a number of different approaches. And those include flooding, pain exposure, stress loading, sensory re-education or sensory training, and graded exposure. So what is desensitization? Well, it's a commonly used intervention for neuropathic pain, specifically in the area of upper limb rehabilitation that I practiced in and most familiar with. 100% of practice survey respondents who were asked about how they managed complex regional pain syndrome used tactile desensitization either always or frequently, and that was a really recent survey. 84% of an expert panel used desensitization for sensory relearning after nerve injury. And yet, even though we see that it's commonly used, it's actually quite poorly defined in the literature. And it's really not clear always when you look at a paper, are they talking about desensitization as direct stimulation of the painful area? Is it something that should be stopped if the person experiences an increase in pain, or is it actually about sensory re-education of adjacent areas as tolerated? So let's try and break down some of the concepts. If we defined desensitization as being the direct stimulation to the painful area, and that's how it was initially posited, then we see that it's aligned with the gate theory of pain. And many of the interventions using this approach were developed in the time period where the gate theory was the dominant theory. However, if central sensitization is present, the gate really isn't working, and it's kind of illogical for us to expect that this will be of benefit to our clients. In contrast to direct stimulation, the concept of sensory re-education is about graded application of stimuli, typically to an area adjacent that has hypoesthesia or altered perception. Graded exposure is a different concept yet again, and I would say I see that as being more psychologically based and coming from that lens. That's not really the focus of my talk today, but I just want to say there's certainly evidence for this and a huge place for it in rehabilitation approaches to pain alongside pain neuroscience education as well. But perhaps one of the reasons we have difficulty conceptualizing desensitization is that we haven't done a good job of categorizing what it is we're actually trying to address. I've come to appreciate hypersensitivity, despite me using it in practice and using my colleagues using it in practice almost as a slop bucket term. I've come to appreciate that it's not really a helpful label, because we haven't really been precise about what it is. Is it an increased response to a noxious stimuli? Actually, the more precise term for that is hyperpathia. Is it an increased response to a non-noxious stimuli? Well, that would be hyperesthesia if that's perceived as just an elevated response, or allodynia if it's perceived as being painful. What about an inability to accurately perceive or discriminate or localize different sensory qualia? Well, those would typically be labeled as hypoesthesia or dysesthesia, or might even represent summation if it's difficulty in localizing because it's perceived in a much larger area than where the stimulus is applied. And in fact, the construct of hypersensitivity more broadly might be very complex, because perhaps involves some elements of fear of movement, because proprioceptive inputs are part of this idea that we might target with desensitization, that it might include elements of pain-related anxiety. It may involve some underlying predisposed sensory aversion or somatosensory hypersalience, so an increased awareness of sensations that are coming in. Perhaps it's related to altered body perception, and that's something that's talked about a lot in the areas of complex regional pain syndrome and phantom limb pain. And it's even got elements of cold intolerance if we think about thermal stimuli. And again, I would say argue that cold intolerance is probably one of those terms that has a lot of different concepts that tend to be lumped in together under that term. So if we start to think about sensitivity, well, then that kind of leads us into the concept of central sensitization, which has been defined by the International Association for the Study of Pain as increased responsiveness of nociceptive neurons in the central nervous system to their normal or sub-threshold afferent input. In other words, thresholds, what it takes to create a response, gets lower, and the responses get bigger, disproportionately bigger, in fact. And so central sensitization applies when we know what the input is, the stimulus, and what the output is, what's the neural response. But we often can't directly measure what's happening at the level of the neurons. And so clinically, we only infer it. It's indirect assumption about the phenomena because we're seeing things like hyperalgesia or allodynia. Other features of central sensitization are spontaneous or central activity. In other words, where we're seeing firing of the neurons without that external stimulus, as well as increases in the receptive field of the somatosensory map. And there's a question mark there because, again, this is based on some inferences because we're often not able to directly measure the neuron activity in live subjects. We're only looking at the inputs and outputs, and we're not necessarily really understanding fully all of the interactions that are happening as well. Can this be spinally mediated? Is there a peripheral contribution? Well, yes, but there may also be purely central features as well that are really relative to cortical changes. So if we think about desensitization and why it might work, there really are 4 potential elements. We can think about the inputs, and those might be somatosensory like tactile, vibration, or thermal inputs, but they could also be visual inputs. And certainly the area of mirror visual feedback is a way that we think about actually trying to augment the signals that are being used to create a sensory experience. We can think about inhibition and facilitation that happens at the level of the spinal cord related to desensitization or sensory stimulation. And then we can think at the level of the brain that we actually may want to be strategic about trying to develop new memories to manage our emotional responses to sensory experiences, as well as having a conscious appreciation of the localization of a stimulus and the qualia of that. So you can see there's both bottom-up and top-down potential depending on the approach that we're using. And we hope that those result in the inhibition of pain and the facilitation of movement at the level of the spinal descending tract. So what is the evidence for desensitization? So 𝐒𝐔𝐁𝐄 and colleagues, of which I am one, published a systematic review this year looking at management of hand dysesthesias after peripheral nerve injury. So a very focused group that we were looking at. And we identified 3 papers that addressed desensitization. One was a proof of concept study that was just published in the French literature, but there were 2 studies that were again come out of the hand rehab literature that looked at allodynia and looked at hypersensitivity. But when we looked at the quality, all of them were gauged to have a moderate to high risk of bias. So the Love-Jones study, which looked at allodynia and neuropathic pain, they specifically were targeting areas of dynamic tactile allodynia. They did a small study, so about 20 people, but 2 of the people dropped out because they were unable to tolerate the sensory stimuli that were applied. So on the first visit, they gave people a heat stimulus, sort of a comfortable heat stimulus, and then the second one was with a comfortable tactile stimulus with a cotton swab. And those treatment times or intervention times were actually separated by about a month. And what they looked at was the immediate response. And they showed that about half of the people would have an immediate response that was a reduction in the area of allodynia, and that would last for about an hour. And they posited that those that benefited probably had some kind of segmental spinal response. But they also concluded that the stimulation didn't really engage the descending noxious inhibitory control system because they weren't seeing a change in that dynamic allodynia. And in fact, what they noted was that the maximum benefit happened about 20 minutes after the delivery of this stimulus. Gorison and Sutherland looked at people after hand injury or hand surgery, and in fact, most of the population were people who had had a carpal tunnel release. And patients were excluded if the touch evoked increased pain. So they asked people to actually do repetitive touching of the sensitive area for at least 3 times a day with the textures provided until the area became numb. And most of the time that took between 2 and 5 minutes. And they asked people to do that for 6 weeks. And at the end of 6 weeks, they reported that people did have a decrease in pain, a decrease in the area that they experienced that pain, and they reported improved function. But again, the people were automatically excluded right at the beginning if rubbing actually made their pain worse. Another study that I think is worth considering is done in the area of complex regional pain syndrome, and that's the idea of pain exposure physiotherapy, which really involves desensitization and loading, so resistance exercise, passive range of motion, tactile desensitization. The sessions that this was done by the therapist to the client beyond, above and beyond their pain threshold. And they asked the person to also continue it and to self-administer this kind of noxious stimulus as their home program. It was an RCT, but they were not able to find any between group differences. They did note it was underpowered, but one of the reasons it was underpowered was that they had to exclude anybody that had negative pain beliefs. So, and when they were trying to recruit, they found a number of people actually weren't allowed into the study because they had catastrophic pain beliefs. What's the evidence? Again, there's another trial in CRPS where it was multimodal care, and the occupational therapy component of that was described as involving stress loading and desensitization, as well as graded motor imagery, as part of this multimodal program that took place 5 days a week for 4 weeks. This was a retrospective cohort, and they didn't report any improvements in pain, but again, reported better physical function. So if we look at the evidence for desensitization, thinking about it being defined as direct stimulation to the painful area to adaptively raise the threshold, it's aligned with the gate theory of pain, but we see there's really no high quality evidence in this area. Does that mean it doesn't work? No, but it certainly suggests it doesn't work for everyone. And we saw that people who had increased pain with stimulation were already excluded in most of the studies. So I think we need to really do more research to identify who specifically might benefit and how to help move the short-term benefits that were generally seen to translate into lasting benefit. I would like to posit that probably most of the people who benefit are people who have relatively acute and focal pain and dysesthesia. But certainly we wouldn't expect it to benefit people who have any evidence of central sensitization. Is it relevant to rehab? Well, certainly we may think that some of the effects are actually due to the more generalized psychological exposure and not just to the somatosensory stimuli that happen with this type of program. And we may want to think about, can we control for that when we're doing studies in the future? Should we be focusing on static stimulation like localization of touch, for example, as was done by Lorimer Mosley and 𝐂𝐑𝐈𝐁𝐄 in their paper, rather than dynamic if we're thinking that that's actually going to be the most effective modality? And I think there's an interesting observation in one of the original papers on desensitization that talked about considering gentle compression as a form of desensitization because you're actually giving a continuous signaling of pressure, and that
comfort that that gives may actually be a form of desensitization rather than a guarding mechanism. So what about sensory stimulation? Is there any evidence for that form of desensitization? So Kintal rated all 3 papers on somatosensory rehabilitation that were identified in the systematic review as having high risk of bias because the reporting tools specifically were not validated. We've since published the validation materials for the testing for allodynia that was used in those trials, but that still is something that needs to be looked at in a lot more depth. There was a prospective crossover study that was done by Mosley and White, so very short-term follow-up using this idea of tactile discrimination training. Again, some risk of bias with that. A prospective cohort study that looked at acute post-amputation pain. This was mostly in lower extremity amputations, and it was nurses who taught people to self-administer while people were in hospital, so very acutely implemented with the principle that desensitization was gentle massage and percussion over adjacent dermatomes that would help to start the cortical remapping process. Lewis and McCabe, who have done extensive work in the area of complex regional pain syndrome, call it desensitization, but it's actually, I would label what they describe as more of a sensory re-education approach, and they use it to address body perception disturbance by cortical reorganization, using comfortable tactile stimulation of adjacent areas. But again, it's at a level 5 level of evidence, so it's a literature review and some nicely described case studies, but certainly not high-level evidence. So if we look at across the different approaches that we have that fall more under this sensory re-education idea, really we want to take a summary that that's targeting higher level discrimination functions of sensation. So the idea of localization, differentiating shapes, differentiating textures, rather than just flooding or immersing and having people experience somatosensations, the idea being that we're trying to discriminate and make a discriminative judgment and compare and contrast. That seems to be the key focus in sensory re-education. And that also goes for using kinesthetic inputs. I know I've been using tactile examples, but the same applies for kinesthetic and temperature inputs as well. The concept of counterstimulation, that term comes from somatosensory rehabilitation, which again is sort of a specific approach to sensory re-education. But the principle behind that is that you want to provide stimulation on the same nerve pathway or on an adjacent spinal segment, so an anatomically related area of application of sensory stimuli, but where the sensation is normal. But again, the idea is that the input is being put into the same nerve pathway and will actually then travel through the same spinal segment. The final concept related to that from somatosensory rehabilitation is the idea of minimizing evoked pain, because we're not trying to stimulate directly over the area of pain or allodynia, but that we're trying to minimize any activities that evoke pain in the painful spot. So by minimizing that, then we try and identify where is that flare-up point, and work below at building up the tolerance to those types of activities below the flare-up point. So again, much more aligned with the model of the pain neuromatrix. But put it all together, and we still really don't have any high-quality evidence. Yes, it's more aligned with our contemporary principles of neuroplasticity and recovery, but we still need a lot more research in this area. So what's the relevance? I would encourage people to think about how can they employ ideas around sensory education over areas of hypoesthesia and dysesthesia, but to avoid doing direct re-education on allodynia. And I think one of the key principles is to think about almost a somatosensory mindfulness during the process of stimulation. one of the challenges with this is if you're self-administering that, and again, we know that often having the person do it on a regular basis is important to support positive neuroplastic change. We need to do it a little and often is often the adage that's used. And working on discriminative sensation without visual cues is something that's really hard to do for yourself. So instead of working on trying to make those discriminative judgments without visual cues, in other words, with vision occluded, then we really want to have people be mindful and instead focus on comparing and contrasting the sensory experiences. So trying to discriminate between the subtleties of, is this warm or is it cool, rather than is it hot or is it cold? And comparing that with the idea of how does that feel on a normal area of skin or an adjacent area of skin compared to the area that we're trying to stimulate. Some other principles that I think are worth thinking about when we're applying this with our clients. There was a great paper by Jocelyn Harris and Andrea Hebert, who are a couple of my colleagues from McMaster, full disclosure, but they wrote a paper a couple of years ago looking specifically at motor imagery, but I think the principles in terms of grading sensory stimuli actually apply very here, because it's really thinking about how do we grade the modalities, so moving from a more comfortable stimuli to the more noxious elements, thinking about that relative to positioning. So again, that may be part of setting up the environment, but it may also be part of minimizing movement so that we're not getting multiple stimuli related to proprioceptive stimuli as well as tactile stimuli. Thinking about using things as part of a task so that we are including and grading that element of motor demands. Thinking about the timing, how many repetitions, how often are we asking people to do that, but also this idea of preconditioning. So Dr. Doidge in his talk earlier at the conference talked about the fact that we really can't develop positive neuroplasticity when our autonomic nervous system is on high alert. When we're in fight and flight, that's not the time that we actually get a good response to retraining the brain. And so we want to think about preconditioning by having people do relaxation practice, perhaps yoga, like Shelley's about to talk about, where we're thinking about how do we set people up for success by preparation for the re-education that we're going to undertake. Thinking about how we use learning, and perhaps using some novel tasks will actually help to stimulate new learning and help people to maintain what is being laid down in terms of those new memories and new experiences. And again, thinking about the internal focus versus external focus. There's a rich literature on this in movement from the kinesiology point of view, but I think we can also think about it from a sensory perspective as well. Is it an internal focus on this is what I'm experiencing versus an external focus of thinking about this is actually what the object feels like? And so if we think about, can we externalize our focus to these are the qualities of the object, does that actually help to reduce the kind of threat value of that object and help us to actually get better learning from that sensory re-education intervention? So I'm more than happy to share my slides with folks because I have a lot of references and resources that I'd be delighted to share. And just posted my email and Twitter for questions as well, but looking forward to discussing